go ahead and get started, and hopefully everyone can hear us. Thanks for being with us today with Dr. Nora Lamartine. She's going to be talking about pregnancy and diabetes. This is a 1-hour presentation. It will be available for CME credit. As for that, a few disclosures. There is no financial support for this activity. The planners or presenters have no relevant financial relationships to disclose. Questions will be available throughout the presentation, so I'll help Dr. Lamartine keeping an eye on the chat if you have anything there. And I think that is it. Thank you so much for being with us, Dr. Lamartine. I'll hand it over.
Hello, I am Nora Lamartine, and I am practicing medicine in Rio Arriba and Taos counties. I grew up in New Mexico. I went to school in Colorado and then did my residency in Massachusetts. And I did an OB fellowship in Texas. After all of that, I came back home. I am part of El Centro Family Health, which is a federally qualified health center. And most of the prenatal patients that I take care of are uninsured or underinsured. So I would say about 90% of them don't get their care through regular insurance pathways. So that will kind of color a little bit of the discussion today, but I think it's a good way to look at things. Pursue me. All right. So this is the goal from today's talk. So we're going to look at insulin resistance and fertility, opportunities to improve pregnancy outcomes in the first trimester, gestational diabetes screening, and managing increased type 2 diabetes risk after delivery. So I am well aware that not everyone who does family medicine does obstetrics or even prenatal care, but I think that this topic applies to everybody in lots of different ways. I'm going to try to hit on that as well. Okay. For most of this lecture, I'm talking about men and women, and I just want to take a second to acknowledge that some of our patients aren't going to fall into these kind of plain 2-category naming systems, and that you might have couples from all different backgrounds who come in and are looking to talk to you about fertility or pregnancy or diabetes for that matter. During this talk, I'm going to talk about women and females, and what I'm talking about are patients who have uterus and ovaries. And I'm talking about men and males to talk about patients who make sperm. I'm going to start with a question. I don't know how many people are on, but we'll start with it and have you put answers in the chat. So Donnie and Marcella come to see you in the clinic. They've been trying to get pregnant for 5 months and are concerned because cousins and friends seem to be getting pregnant more quickly. You've been taking care of Marcella for many years, and you know she has polycystic ovarian syndrome. What recommendation will make the biggest impact on her fertility? Okay. So the answer is letter B, losing 5 to 10 pounds. So starting metformin will help her ovulate, but it won't help with a variety of different fertility factors. Losing 5 to 10 pounds will improve several different reproductive parameters. So it'll help improve her fertility overall with cycle regulation and ovulation. It'll help prevent spontaneous abortions. It'll also help prevent her developing preeclampsia or gestational diabetes in the future. St. John's wort is not something I would ever recommend and has no usefulness here. And any opportunity to get someone who's thinking about fertility on a prenatal vitamin is a good opportunity. All right. So high blood sugar, insulin resistance, and diabetes can affect both males and females in their fertility journey. So lots of times, because we're taking care of families and we see both partners in a family, they'll come in and talk to us when they're trying to conceive or they're having infertility issues. In men, having high blood sugars or hyperglycemia can actually affect spermatogenesis. So the sperm may not be the right shape and it might not move the right way. And so if it can't get up and into the fallopian tubes to meet the egg, and then it can't penetrate into the egg, you're not going to get a pregnancy. So we don't often talk to male patients about fertility, and we don't really worry about, are they trying to conceive, are they not, do they need to be on birth control? We might talk to them about sexually transmitted illnesses, but if you have a diabetic or pre-diabetic patient, it might be worthwhile talking to them about their family planning desires, as it can definitely have an impact on the couple's fertility. Now, women are a little bit easier to think about because we kind of focus on that more often. In women, insulin resistance and obesity can both alter ovulation. So like we just talked about, in women with PCOS, a small amount of weight loss, 5 to 10 pounds, can really make a difference in their fertility and the safety of their pregnancy going forward. It's not incorrect to treat them with metformin, and if they're having symptoms and that's helpful, then go ahead and do it. So when we're looking at the pair, we need quality sperm, healthy eggs. We need the egg to be dropped at the right time, and we need to have it in the right setting. So there's lots of different factors there that can be affected by glucose metabolism. Okay, so your patient comes in for their first prenatal visit. And this is an opportune time to start thinking about weight gain, gestational diabetes, and what we can do to help these patients. So most patients, when they come in for their first prenatal visit, are going to get 5 or 6 tubes of blood drawn. We're going to learn everything about them and their history. And some of the things that may not necessarily be on the ACOG form that's built into our EMRs are things like their social economic background. Do they have regular access to food? How are they getting to their appointments? How are they going to pay for their care? So women from lower socioeconomic backgrounds are more likely to develop gestational diabetes. I'm sure we can kind of think of lots of reasons why that might be. And women who are pre-diabetic before getting pregnant or have who are obese or strong history of diabetes in their families should be screened with an A1C in their early pregnancy. So as long as they're in the first trimester, this will still be a useful measure. Women who have a pre-diabetic or diabetic A1C and receive counseling on nutrition and weight loss and safe weight gain in pregnancy are going to have lower rates of large for gestational age babies, gestational hypertension, preeclampsia, and lower C-section rates as well. So it's really worth talking to them early on because you can prevent a whole slew of issues later on. I know at our health center, we have community health workers, and some of them are very well trained in providing diabetic nutrition education. So I'd encourage you to work with your care team and see if there's someone who is particularly skilled in talking to patients about their nutrition and coaching on a diabetic diet. So it might be a community health worker, it might be a nurse, it might be you. And if it means more visits, then it's worth doing. Weight gain recommendations. So a lot of patients have no idea how much weight they're supposed to gain, and they kind of glean that from the internet or family members. It's definitely worth talking with them about. And if you have a patient who's overweight, she is well aware that she's overweight. So you want to use, gentle speech with her and motivational interviewing skills to talk with her about that. Pregnancy is often a time where women are motivated to lead healthier lifestyles, so you can bank on that.
Dr. Lamartine, we have a question in the chat. It
Okay.
says, would you still do a GTT at 25 weeks if normal A1C early on?
Absolutely. Absolutely. So we'll get into that a little bit later. but just because they're normal at the beginning of their pregnancy doesn't mean they will be later. Okay. So Karen comes to see you for her first OB visit. This is her first child, and she's motivated to do her best to have a healthy pregnancy. She's overweight with a BMI of 30, and she wants to know what she should be eating and what should she be doing with her diet. What is her recommended weight gain during pregnancy? If you want to put it in the chat, you don't have to own it out loud. So for her BMI, we want her to gain 11 to 20 pounds. This is a little chart that has different BMIs and recommended weight gain. I would like to say most of our patients are normal weight, but in reality, that's not the case anymore. So a lot of them are going to fall in the 15 to 25 or 11 to 20 pound range. And it's good to talk with patients not only about what you expect their weight gain to be, but when it should happen. And for most of us, you've seen your first trimester patients lose weight. They get that morning sickness, they're not feeling well. So watching that and talking with them about how much weight loss is safe. Okay. And of course, if your patient has a multiple gestation, twins, triplets, their weight gain recommendations are going to be totally different. I'm also going to assume that you have maternal and fetal medicine involved, so I'm leaving that out for now. And what kind of diet should pregnant women be eating? If you can start encouraging them to have a healthier diet, what sorts of things might be part of that? So we want to move away from processed foods and go towards whole foods. Fruits, veggies, lean protein. If she can stand to eat fish a couple times a week, that has lots of great things in it. Whole grains, foods that are high in vitamin D. And if she's pre-diabetic, then we want her to start following a diabetic diet. So managing her carb count, looking at how many carbohydrates, how much protein and fruit and vegetables she's putting on her plate. This can be challenging for women in their first trimester. So working with them on things that they're going to be able to tolerate. Okay. Gestational diabetes screening. So this kind of goes back to that question earlier. We want to do this between 24 and 28 weeks, and assuming there are no other risk factors. So for most of your patients, this is going to be when you want to do this screening. We're doing it between 24 and 28 weeks because this is kind of a tipping point for our bodies and hormone regulation. So as pregnancy progresses, your body has higher insulin requirements. If someone is healthy and non-diabetic or not pre-diabetic before they get pregnant, their body catches up to that and their pancreas can make the extra insulin that's needed. If they have gestational diabetes, their body may not be able to keep up with the increased insulin demand. And around 24 to 28 weeks is when you're going to be able to detect that with glucose screenings. So in this picture, there's a couple different numbers listed, and I'm going to show that on the next slide. But there is a 50 gram, 75 gram, and 100 gram glucose strength. So you have two options for testing for gestational diabetes. The one that I think most of us are familiar with is the 1 hour screening, followed by a 3 hour test. And the other option, which is totally fine with ACOG, the ADA, and is a WHO recommendation, is a 2 hour glucose tolerance test. So neither one of these is more correct or more accurate than the other. They both work just fine for diagnosis. So you really need to think about your patient and what you want to offer them. Doing the 1 hour test and being done is really convenient. It's also one where they don't have to fast. So patients can have a small protein meal before they do that test. So this might be a good option if someone's still suffering from morning sickness by the time you're getting to this testing. And it's also a great option if you think they're going to be negative. We still need to test them anyway, but it can kind of get them out in and out faster. I use the 2-hour test actually the most in my practice for a couple different reasons. So a lot of my patients are still working and they need that income as much as possible. So every time they have to come in for a visit or potential testing, they're taking time off from work and they're losing money. And they may or may not have a car or driver's license, and then the cost. So a significant portion of them actually do end up with gestational diabetes. So if we can get the testing down to a one-time thing, it makes a lot more sense for their social situation. What happens if your patient throws up the liquid? So this happens actually a lot. And you can substitute 28 brand name Jelly Bellies instead of a 50-gram glucose drink. Your patient still needs to eat them fairly quickly, and I wouldn't do it the same day that they threw up their liquid, but it has the same glucose load so that you can get an accurate test. I haven't read anything about applying that same to the 75 or 100 gram. So if you do end up going on to the 100-gram testing, she probably will need to drink the liquid. You can give nausea medication, but you want to make sure that you're not giving something that's going to slow her digestion, because that will affect the results. Okay. So you get your results back from your patient, and they are screening positive for gestational diabetes. So when I get those results back, I usually get them started right away with checking a blood sugar log. I have them checked 4 times a day. So I'm looking for a fasting. So that's going to be there before breakfast, and then a postprandial. You can do 1 hour after they eat or 2 hours after they eat. Most people seem to do better testing an hour after they eat, because it's still fresh in their mind. They're ready to test. Then 2 hours, they've already moved on to something else, especially if they have other kids. The other important thing I do with this is have them make notes about what they're eating. So this can be a great tool. I find that when I have them back in a week later, they'll say to me, oh, when I have this, then my blood sugar is high. So I stopped and the numbers went down. So before we even begin to counsel them, they're already ready to see the patterns and what's making their blood sugars high. On the bottom half of the screen are goals for these numbers. So when we're treating someone or working with their nutrition, we want to get a majority of their blood sugars down under these goal levels. So fasting is going to be less than 95, and postprandial is going to be less than 140. So I know Dr. Reyes has used insulin because she's talked to me about it. So that's kind of the first thing that comes to mind. I would encourage you to think about nutrition first with your patients. And this is going to be something that you kind of have to weigh the risks and benefits of. So when you look at the numbers, you'll have a sense about whether or not they're close enough that you can get those down with nutrition. So engage your care team, get your nutritionist or your educator on board right away to start meeting with that patient. It can make a huge difference in their blood sugar levels, and you may be able to avoid medication. So insulin is our most recommended treatment, and depending on where you're at regionally and with insurance, what insulin you use will vary. For the most part, all insulins are safe to use. Traditionally, we get patients on a long-acting and then short-acting for meals. You can also do a 70-30 preparation. That's okay too. The other option is metformin. So metformin has similar outcomes to insulin, and there's actually better glucose control with it and lower weight gain. But we don't have long-term studies for effects on infants after they're born for mothers who are on metformin. So it's not our first line, but for some of your patients, it might be the best option. I'm sure we can all think of a patient who's absolutely refused to do injections. No matter what, they're not going to do it. So that might be a patient with whom metformin is good. Perhaps the cost of insulin is prohibitive, and they can get metformin for $4. So that makes it a better option. It would encourage you to avoid using any sulfonylurea. So once the baby is born, there can be longer lasting insulin regulation issues. So just like in our geriatric patients, when they go into the hospital, they've had a sulfonylurea and that can last like days and you can't get their blood sugar under control. The same thing can happen with babies after they're born. With a lot of this stuff, you want to try to match what your maternal fetal health specialists are doing in the area. So if they always use insulin, then that should be your go-to. If they're more willing to start people on metformin, then that makes it an okay option. Laura was diagnosed with gestational diabetes after a 26-week glucose tolerance test. You sent in a prescription for a glucometer and testing supplies when you called her with test results last week. She brings in her log today and 85% of her postprandial blood sugars are elevated, but all of her fasting blood sugars at goal. What are your next steps?
Sorry, Nora, I think maybe we were typing in the chat, but we'll do the discussion. I'd say since she's 85% are elevated, we might want to think about maybe medication. I guess I remember if it's above 50%, then you want to think about more like pharmacologic along with the dietary and nutrition goals.
Absolutely. Good answer. So that's exactly it. She probably is going to need some medication and then trying to decide what kind of insulin she needs. If her fastings are great, maybe she doesn't need a long acting, and getting her set up with your nutritionist. Are there any questions in the chat I need to answer? I unfortunately can't see it.
I think you're good, Dr. Lamartine.
Okay. So this is a map of farmers markets in New Mexico. And the yellow color are farmers markets that do double up bucks for SNAP benefits. And orange are farmers markets that do not. And I think that for most of the people on this phone call, their region has a farmers market that will do double dollars for SNAP. So I bring this up because nutrition and food deserts and cost of healthy foods is a huge part of gestational diabetes. And in our clinic, especially in our TAS clinic, our community health worker will meet with our gestational diabetes patients on Saturdays and actually walk through the farmers market with them. So helping them go up to the stands, use their SNAP benefits, think about recipes that might work with the foods that are available that day. And it also helps take away some of the fear about shopping. So we think a lot of patients don't know how to read food labels, and a lot of patients probably don't know how to pick out vegetables or interact with farmers market food stand people. So having that helping hand there can make a big difference. Okay, the cost of insulin. So Walmart will has insulin at a pretty reasonable price. So you can get NPH and regular insulin at Walmart for $25 a vial. You can also get a glucometer and test strips at Walmart for fairly reasonable prices, $9 and $20 for test strips. But if we're looking at these test strips, that's really going to be about a month's supply. They can get insulin, syringes, and needles on Amazon fairly inexpensively, $13, and alcohol swabs. Once you start to add all of this up, though, it can become quite a chunk of money. And so I know at our federally qualified health center, we can dispense a glucometer for free and then test strips through our pharmacy. We can also do just about any insulin through our pharmacy. We have cash prices. I want to say they range from like $5 to $15. And then there's a dispensing fee. So if they're picking it all up at the same time, they pay the dispensing fee once. We can also give them a 90-day supply of their insulin. So when patients are talking to you about the cost of insulin and maybe metformin is better, this is something to kind of keep in the back of your head, that there really is a lot that can go into how much insulin is going to cost. So you know your patient has gestational diabetes, and you're trying to decide, does she need additional monitoring? So like every slide in the presentation, you want to go with what your regional maternal fetal medicine specialists are and the OBs that you work with, so that you're all kind of on the same page. But in general, if your patient is a diet-controlled gestational diabetes patient, they don't need additional monitoring. So they don't need the biweekly NST and BPPs. And that's not to say that they may not need an extra ultrasound. So if their dates and size don't match, they might need an ultrasound looking at size. Or if you just are really worried about macrosomia and you want to get an estimate of size before their delivery, that would be appropriate. If they're on medication treatment, then you do want to get this screening testing. So we're doing biweekly NSTs and BPPs. And depending on where you are and equipment in your office, this can potentially be something you do yourself. And it might also be something that you send them to labor and delivery for, or they can get done at a regional imaging center. In general, if the only issue is gestational diabetes, then this additional testing would start at 32 weeks. If your patient has preeclampsia or something else that's going on, then that might start soon. We're considering control to be 90% of their readings at goal. Okay, delivery. So most of the patients that we're managing without additional input are going to be these diet-controlled gestational diabetic patients, and they should have normal delivery timing. Like pretty standard with the rest of our patients, we don't want them to have post-dates deliveries, and with the increased risks from that. If they're medication controlled, then we want to do an induction at 39 weeks. If they're on medication and they're uncontrolled, then you might do your induction between 37 and 39 weeks. And again, if your MFM tells you something different, then you're going to go along with their recommendation rather than what you might think. Now you've delivered the baby and you're watching them and making sure that you're not going to miss anything there. So infants in the hospital newborn period, after they're born to mothers with gestational diabetes, are at risk for macrosomia, respiratory distress, hypoglycemia, and hyperbilirubinemia. So the macrosomia is directly related to the gestational diabetes. And these end up being bigger babies. Being a bigger baby and having a heads up about that can sometimes change the way that you manage labor or the equipment or personnel that you might have in the room during a delivery. Thinking about things like shoulder dystocia, or potentially even needing a C-section if there's pelvic disproportion. So respiratory distress can be common in these kiddos. This is not directly related to insulin regulation or gestational diabetes, but is associated with these patients being induced before term. So if the baby's induced around 37 weeks, then you're more likely to have respiratory distress related to the prematurity. Hypoglycemia. So this is a result of transient hyperinsulinemia. So baby's coming out with extra insulin from mom. And hospitals usually have a protocol for this. I know at our institution, we do fairly frequent blood sugar monitoring in the baby with scale sticks. We encourage early breastfeeding. If we think milk is not coming in, blood sugars are still dropping, then we'll do supplementation with formula, and only as a last result will we put them on a glucose drip. If your baby gets on a glucose drip and you can't figure out what's going on, you can't get them back off, then you're going to need to do additional testing because that might be something unrelated to the gestational diabetes. The last one is hyperbilirubinemia. So this is again often related to prematurity, but this one can also be directly from maternal glycemic control, being a large baby or having polycythemia. I know in our institution, we screen for this. We do transcutaneous, and then we'll do blood draws if we need to. But it didn't, 3 years ago when I started there, that wasn't the case. So the newborn doctor had to say they wanted to test for bilirubin. So if that's the case where you are, then you want to be thinking about that, and this would be a good indication to get that testing. Okay. Laura comes in for her 2-week postpartum visit. We stopped her insulin after delivery, but asked her to keep her blood sugar log going when she went home. She was instructed to use her insulin R if she had a reading above 140 based on her sliding scale that she previously had. What information do you want from her today? What lifestyle interventions would you recommend? And when will you test for type 2 diabetes?
I guess in terms of like what more information is just like how is she keeping up with her lifestyle? I'm not really sure. In terms of when to retest, I'd say in 6 weeks, 6 months, A1C, I can't remember.
Yeah, exactly. So you want to know what she's been doing since she got home. Is she exercising, which she might not be at this point. She's probably just trying to sleep as much as possible. But what is her diet looking like? Is she breastfeeding? And how often does she have to use her insulin? And you're right, you want to test her for type 2 diabetes sometime between 4 and 12 weeks postpartum. So it is not uncommon for your patients to be able to go off of insulin before they leave the hospital. Once the placenta is delivered, insulin resistance changes really quickly. So this is something you want to be watching for before you discharge someone home. If I end up sending someone home with insulin, I often try to empower them to monitor their sugars and decrease the insulin if they need to. And that can be them doing it independently, or if they feel like they need to give me a call before they do it, but really trying to avoid hypoglycemia. So to test for type 2 diabetes after the delivery, you want to use a 75-gram glucose tolerance test. We're still close enough to them being pregnant that an A1C is not really going to be a useful test at this point. And with that kind of 3-month window, you're going to be catching the end of the pregnancy. We want to continue to support her to have a healthy lifestyle. So we'll talk about kind of children and mothers on the next slide, but she's not at risk for type 2 diabetes. So as much as we can do to help her have a regular exercise plan, healthy eating is going to be good for her. It's going to be good for her kiddo. It's probably going to be good for her partner. So she may need to keep meeting with your nutritionist. And once she's a year out, then we want to keep screening her every year to 3 years with an A1C. So there might be things that tip you off that you need to do that sooner than every 3 years and switch to every 1 year. She's gaining weight, going to the bathroom a lot, any sign of diabetes, and you want to be testing for it. But this is going to stick with her for a lifetime now. And then last kind of interesting point is that breastfeeding can actually help improve her glucose metabolism. So we all know breastfeeding is wonderful for lots of different reasons, but it's good to start encouraging these moms to think about breastfeeding even while they're pregnant, because it's going to help with that glucose metabolism and insulin resistance after their delivery.
Nora, can I ask a quick question? Well,
Sure.
I don't know if it'll be quick, but so in terms of it's recommended to do an A1C early on in pregnancy because that's, you know, kind of looking more if like someone was pre-diabetic already to begin with or undiagnosed diabetes. And then we shouldn't, or it's not recommended to do it during pregnancy. But can you remember like why? I think you were mentioning it now, but
yeah.
what's
So during pregnancy, insulin resistance is going to change so rapidly because of hormone shifts that if you're looking at a 3-month aggregate with the A1C, you might not pick up on that insulin resistance as it's happening.
That makes sense. Okay, perfect. Thank you.
No problem.
Dr. Lamartine, I have a question.
Sure.
In addition to a dietitian and a nutritionist, what would be the other, I guess, support that would be offered to someone postpartum to manage this?
In an ideal world, we'd have someone to exercise with them and someone to teach them like how to cook. And everyone would have access to fresh foods. Nutrition is really the biggest one that we can get at, but
Okay.
You're right. If we could get them exercising, that would be great. I know some places have like a walk with your doc program, where doctors will walk a mile each day with their patients. So getting them in something like that can be big too. There are some, I know some different YMCAs have a diabetes program, and if your area has one, you can connect them with that. And then they'll do exercise with them.
Excellent. Thank you.
No problem. Okay. And then children. So moving out of the neonatal period, infant time, to when these kids are a little bit older, there's lasting impacts from their mothers having gestational diabetes. So these kids are more likely to be obese and glucose intolerant. From the articles I was looking through, it's not entirely clear to me if this is directly because of the insulin resistance they experienced in utero, or if it has some relationship to the lifestyle that their family may also have. But either way, these kids are going to be at a higher risk for obesity and glucose intolerance. So if you are privileged enough to be the kiddo's PCP, I'm going to be keeping an eye on that as they grow up. There is an increase in cardiovascular morbidity. This was less than 1%, but it is a significant increase. There's also an increased incidence of impaired neurodevelopmental outcomes. And interestingly, these seem to show up earlier. So it's going to be even more important to be doing our autism and developmental screenings in these kids. I would hope that we're doing them all the time, but we want to make sure we're really keeping up with them and doing them on time. A lot of these articles had come out in the past 2 years. So this is an area of research that's rapidly expanding and growing. It'll be interesting to see how this develops over time. Okay, that's all I have for you guys.
Thanks, Dr. Lamartine. That was very, I think, comprehensive from pre-pregnancy to post and children. That was awesome. Thank you.
Hello. Hey guys, it's Dr. Andazola from the Southern New Mexico Family Medicine Residency Program. Just wanted to let you know I have 20 residents here. It's okay. So people are freaking out because they can hear me talking on the speaker. So, but there's 20 residents here, or 20-ish people here. I just wanted to let you know that so you can record that. Thank you for your talk. It was awesome. One thing I really wanted to throw in there that we were talking about with healthcare disparities and increased insulin and increased diabetes and increased incidence of obesity and things like that. I think this is a perfect opportunity to throw in the social determinants of health, structural determinants of health, and issues like that, because it's populations that are at risk. And a lot of these things that you just talked about are hereditable, right? So the children have it, and it may be lifestyle issues, it may be social issues, but it could also be hereditary issues, because we do know of what's that called when you methylate genes? Say it louder because I can't hear. I'm old. Oh gosh, I don't remember. So, yeah, but there's hereditable aspects of disease that can be passed on that are socially impactful. So I think as being a family physician, knowing how to treat the diabetes is absolutely important, and knowing how to reduce the risk to the mom and to the baby is absolutely important. But think about the population where she comes from and what's happening in her community, and how do we address that community-wide. So I don't know if you had any statements or any thoughts about that.
It is a huge issue, and I know, yeah, it's for me, it's a lot to think about. So I try to think about each family unit and then how that kind of affects the community, and maybe we can grow from there. So if I can get each family doing a little bit better and connect them with resources to help, then we can do better. But I think trying to take advantage of things like these food farmers markets, public walkways that are a safe place to take your kids and walk with your family, things like that can be, the best combat that I have without being at a level to really impact the community structure or infrastructure.
Well, thank you.
All right, any other questions for Dr. Lamartine?
So Dr. Lamartine, another question, just in terms of working with patients, how would you work with a patient that, let's say, goes the other way in terms of just managing, where rather than, I would say maybe goes a little overboard and just has this sort of like fear of, putting too much into their body, so they don't put enough to manage their gestational diabetes?
I've had a patient do that. She started walking after every meal and was kind of micromanaging everything that she ate. So I am really very blessed to have the community health worker that I have. So we started having her meet with her every couple of days, and they did menu planning, which was really helpful. And they talked about what is too much, and we came up with a more detailed weight gain plan and what was expected and what we needed, and just doing measurements more often. And so some reassurance that weight gain was normal and expected. And then she really was needing those details of what exactly to do.
Thank you.
All right, everybody. Thank you so much, Dr. Lamartine, for this wonderful lecture.